Hi Dad, this is part 2. This is still in the chapter They'll Still Be Dead Tomorrow. Suspended over the foot of the autopsy table is a scale with a metric dial face for weighing organs, a big drum of formalin, the 10% formaldehyde solution that is the catch-all preservative for human tissue, rests in a corner. Against another wall, a soft whir comes from behind the glass doors of the curing cabinets. Inside these, on hangers, blood-soaked garments drip, homicide evidence drying out for laboratory tests or for trial. Autopsy is morning work. Dr. Flomenbaum advised me and Stuart and Doug to be gowned up and standing at our assigned tables in the pit by 8 o'clock. That would ensure us enough time to finish an external examination of the day's first case before the boss appeared. Dr. Charles Seymour Hirsch made morning rounds, surrounded by MLIs and medical students at 9:30 sharp. A pipe-smoking avuncular doctor right out of a normal rock melt painting. Hirsch also always arrived wearing slacks, a tie and suspenders, his keen eyes standing out over a surgical mask. Each morning we would deliver a summary of our cases to him while he scrutinised the x-rays and our findings from external examination. You had to have something to say about each case, but shouldn't venture anything you weren't prepared to back up on the spot. Morning Hirsch rounds could be the most nerve-wracking part of the day. Dr. Hirsch set a tone of quiet dignity in the autopsy suite, and the rest of us emulated it. He showed a fondness for epigrams we called Hirschisms, and like any teacher he had his pet peeves. It didn't take us long to learn them. He hated the phrase consistent with, if the finding was in fact perfectly obvious, and gritted his teeth if we described anything as massive or mild, marked and slight and more specific. When presenting a case to Dr. Charles Hirsch, he had to refer to the decedent as a man, woman, boy or girl, not as a male or female. During our first week doing cases, Stuart presented the body of a man who had been shot by a lady. Shot by a woman, Hirsch interrupted to correct him. Ladies don't shoot people. Morning rounds in the autopsy suite were brief. Our opportunity for follow-up came every afternoon at 3 o'clock rounds, when all the medical examiners got together in a conference room to discuss, and sometimes debate, the day's cases. Dr. Hirsch could take the most jumbled, messy case history and find a way to simplify it for the death certificate. We are not trying to be all-inclusive when we write the DC, he stressed. Just, concise and accurate. For the first 2 months of our training, Dr. Hirsch also led a separate teaching session with the fellows, offering detailed feedback about our diagnoses and early autopsy reports. He taught the 3 of us that the medical examiner's most solemn duty was to make 2 distinct determinations for the death certificate: the cause of death and the manner of death. The cause of death is the etiologically specific disease or injury which starts the lethal sequence of events without sufficient intervening cause, Hirsch recited. Write that down and commit it to memory. Think of it as the answer to the what question. What is the one thing that began the chain of events ending in death? The manner of death is a medical legal classification of the circumstances. The answer to the how question. We group all deaths into 6 categories: homicide, suicide, accident, natural disease, therapeutic complication, and undetermined. We will come to learn that the manner of death affects a whole range of institutions, from insurance companies to the district attorney, from the police department's homicide division to the landlord of the deceased. As one of the identification staff put it during my first week on the job, maybe nobody cares about you when you're alive, but lots of people take an interest once you're dead. Before I was assigned my first post-mortem investigation as an assistant medical examiner, I spent a week in the morgue observing while the senior MEs cut their cases. Dr. Susan Ely guided me through the first day. She was a slight, attractive woman with a daughter the same age as my son, so we bonded and commiserated while changing into scrubs and netting our hair in the locker room. I replaced my glasses with plastic prescription racquetball goggles, which Susan thought were hilarious. I told her I had the same opinion of her Disco Vantage platform shoes. They bring me up to autopsy table height, she half joked. In the pit, I alternated between her table and Flames, observing how two different doctors approach the task of performing the last and most thorough physical exam you will ever have. An autopsy is not the same as the cadaver dissection I'd done in medical school gross anatomy class. Autopsy means see for yourself, and it has more to do with figuring out what went wrong in the body than with exploring the anatomy. An autopsy can take anywhere from 45 minutes to over 4 hours, beginning with a thorough external examination and proceeding from the outside in. I learned to document every piece of clothing and every item of jewellery in the body, not excluding pieces of precious metals studded into unlikely flaps of the human anatomy. If you knew how much hardware some of your fellow citizens are toting around in their knickers, you might see the world as a stranger and funnier place. Since the body and everything on it is my responsibility, I often have to reach into a dead man's pocket and pull out whatever might be there. And people who meet with violent deaths are often engaged in some aspect of the underground cash economy. I once collected $12,400 in $100 bills off a body. I know the exact amount because I counted it very, very carefully, twice. Whenever I found any cash, I would make a point of showing it to the technician, and if no tech was working with me at that moment, I would hold the money up in the air and announce to everyone in the autopsy suite, "I have a wad of cash here." People working for medical examiners have lost their jobs for stealing money from the dead, so it is standard practice for us to announce loudly and in public the discovery of hard currency. Once the body has been reduced to its natural state, I examine it closely for signs of injury and document all findings. To a trained eye, bruises, scrapes, cuts, and penetrating wounds can tell a story. If the body is in rigor mortis, I will pry its fingers open to see if there is anything grasped in the palm of the hand. I found the hair of murderers in the clutch of their victims this way. Suicides by poisoning sometimes still have the pill bottle in their death grip, and drug abusers who overdose may have the needle dangling from an arm. In addition to trauma, we document tattoos, scars, unusual physical features, circumcision, amputation, and birthmarks. Dr. Flomenboim even taught me over the autopsy table. The families of the deceased take the written description in the autopsy report very seriously, and if there is any inaccuracy, if I miss a single old scar, the validity of the entire death investigation might be cast into doubt. Dr. Barbara Sampson, who also trained me in my first New York autopsies, cautioned that seemingly trivial physical characteristics might be important to the family. Tattoos, for instance. I learned this lesson the hard way after receiving a peaked phone call from the girlfriend, named Vera, of a dead shooting victim. In my report, I had written that he had Nera tattooed on his upper chest. I'd also failed to notice a scar on his face. Vera thought I had autopsied the wrong guy. I apologised to Vera and offered to amend the autopsy report. When I poured over the identification photos later, though, I still couldn't find the scar, even though the skin was still its natural colour mostly. It could be that the scar had been obscured in the furrow of his brow or under a 5 o'clock shadow. Maybe it stood out in Vera's memory more vividly than it did on the body. Maybe it had some personal significance to her. Maybe she'd given it to him. Probably, though, Vera just didn't trust me because I misread the name on her boyfriend's chest. Never hurts to be careful, counselled Dr. Monica Smiddy, another of the senior staff. Monica had a distinctive way of speaking with a lilting and falling cadence in a muted Boston accent. She taught me to count everyone's fingers and toes. If the dead man had lost the tip of a finger in a supermarket cart accident when he was 8 years old, everyone in the family would expect that detail to be included in the autopsy report, even if it was totally irrelevant to the cause and manner of his death. Fail to note it and the family won't trust your conclusions. The same rule applied for the appendix. Sometimes the presence or absence of a high-profile organ proves crucial in establishing the identity of the deceased. Dr. Smiddy instructed me to always take sample cuts of the testes in men and ovaries in women, and always count these organs. Some men have one and some have prostheses, and believe me, the wife will notice what you write in the report. So be thorough and cover your bases. It pays to count to 2. Day by day, I practiced the rhythm of the medical examiner's routine. Autopsies all morning, then meetings and paperwork, interrupted and enlivened by occasional trips to crime scenes or to the courthouse to testify. Though it would take weeks before the jitters settled and I became comfortable with my diagnostic skills, I was officially prepared to start working on my own. On July 6, 2001, after 5 days of watching other doctors perform autopsies, I did my first and failed. Chapter 3, See for yourself. Terence Booker was a hospital case, a 26-year-old with sickle cell trait who had died on the inpatient floor of NYU Medical Center. Sickle cell trait is the most common genetic aberration in the world, and almost everyone who carries it goes through life showing no symptoms. Some carriers of the trait, however, can develop sickle cell anemia, a disease in which their normally disc-shaped red blood cells mutate into crescents and jam up the capillaries, impeding the flow of blood. Sickle cell anemia is usually easy to diagnose because patients display a clinically characteristic set of symptoms, including fever, tachycardia, which is a racing pulse, and abdominal rigidity. There is, though, one complication of sickle cell anemia, vaso-occlusive pain crisis, which cannot be objectively evaluated. The blocked blood vessels cause ischemia. Tissues throughout the body starve of oxygen, resulting in acute systemic pain. Ischemia can lead to fatal organ damage in a matter of minutes. So when a person with a history of sickle cell anemia comes into a hospital with severe cramps all over, the medical staff take that complaint very seriously and start treatment right away. Treatment is straightforward enough. Put an oxygen mask over the patient's nose and mouth, hydrate him through an intravenous line, and administer an opioid analgesic painkiller, typically oxycodone or codeine. You know what else happens to be an opioid analgesic? Heroin. Terence Booker was a documented heroin addict who was probably malingering, faking a pain crisis to get drugs. Doctors have no way of knowing whether somebody's lying about pain, really. You can't fake a fever or tachycardia, but pain is purely subjective and there's no test for it. When Booker showed up at the emergency room reporting that he had sickle cell and was hurting all over, the ER staff had to treat him for a possible vaso-occlusive pain crisis. They admitted him as an inpatient and dosed him with the powerful clinical drug narcotic oxycodone. In the middle of the night, Terence slipped out of the hospital. He returned a couple of hours later looking glassy-eyed and slurring his speech. A nurse found him unconscious, called a code blue, and the medical team rushed in with a crash cart. They put a breathing tube down his throat, started CPR, administered a drug to reverse the effects of opiates, and then sparked him up with a defibrillator. The code blue team succeeded in restarting his heart, but it was too late. He was brain dead. His heart kept beating for another 8 days. Then it stopped, and Terence Booker's corpse came to me. My first post-mortem investigation as a New York City assistant ME should have been simple. I started with an external examination of the body, removing the tangle of tubes Booker's hospital caregivers had inserted into his veins and down his throat during their attempts to keep him alive. I documented all of them along with the defects they left in the dead man's skin, and then picked up a large bore syringe to perform the first invasive step of the autopsy, inserting the needle into the side of each eyeball to aspirate a sample of the vitreous fluid. I watched through the eye's open pupil as the tip of the needle came into sight. Dr. Flomenbaum had taught me that if I poked too far, the needle could hit the retina and cause what we call post-mortem artifact. I would later learn to abide by Monica Smitty's count to 2 rule when I pushed the needle into a cadaver's eyeball and it popped out and clattered to the floor. Glass eyes are no longer made of glass, they're made of plastic, and thankfully, they don't shatter. Next, I tried to take a sample of peripheral blood from the big vein behind Booker's collarbone. I wasn't able to get any, so I went instead to the femoral vein in his groin. I knew that once I opened the body up, all kinds of fluids were going to start moving with the pull of gravity, so it was important to get a needle sample of the closed circulatory system before making the first incision. That first incision is the Y cut. Using a scalpel, I sliced from the edge of each collarbone to the breastbone, pushing through the skin, fat and muscle of the chest. Then I cut from this point all the way down the abdomen to the bone at the front of the pelvis. Once this was done, I was able to open Terence Booker's chest like a book, filleting the connective tissue off the rib cage and peeling away the flesh of the belly to expose the peritoneum. The inside of the human torso is divided into 5 major cavities, which contain associated organ systems. The peritoneum is the largest of these and features the digestive tract. Behind it is the retroperitoneal space, home to the kidneys and a few other organs. Each lung is surrounded by a separate pleural cavity, and between these lies the pericardial sac, the heart's own pocket. An autopsy generally tackles each of these enclosed spaces separately, since bodily fluids and blood may be contained in each without the others being affected. I'd been taught that in an ordinary autopsy like this one, without bullet holes or other obvious external complications, I should start with the peritoneum. I slit through the thin lining that surrounds the cavity to take a look. The presence of fluids of different colours and odours might point to liver or heart failure, infections, tumours and various diseases, and I had seen during my training week that a laceration of the spleen or the aorta can leave half a gallon of blood in the peritoneum. Booker's peritoneum didn't have a lot going on. If a patient has a significant amount of liquid in the belly, I have to collect it for measurement using the stainless steel soup ladle I'd bought at housewares stores on East 23rd Street. Many of the medical examiner's tools are a good deal less shiny and exotic than the instruments our colleagues in hospitals use. TJ was aghast the first time I dragged him on a tour of my workplace, on a slow afternoon with no autopsies in progress, and he saw a long, age-worn butcher's knife that looked exactly like a family heirloom his mother uses to carve roasts. Our staff keeps it sabre sharp for slicing organs. It works beautifully. One workstation has a set of kitchen knives in a wooden block. Hanging on a wall is a collection of hacksaws and a pair of large spatulas. A hammer and chisel, TJ said in deepening horror. What do you... No, don't tell me. Turning to my workstation, he pointed to a set of long-handled pruning shears, the kind used for cutting back tree branches. They were engraved with the name of a hardware store. What are those for? You don't want to know, I assured him, but he insisted he did want to know, so I told him. Snapping ribs. After examining Terence Booker's ribs to make sure there were no visible fractures, I clipped each one with those pruning shears and lifted off the whole breastplate, exposing the 2 pleural cavities in the pericardium. I knew that, as with the belly, it was important to note the colour of any liquids in the cavities surrounding the lungs. Green fluid indicates infection, probably pneumonia. Clear fluid means heart failure. Blood, trauma. Booker's lungs showed a little bit of the expected damage from spending a week under mechanical ventilation, but they were otherwise healthy, pink, spongy and soft. A smoker's lungs are bubbly, black, hardened lumps, exactly like those photographs used to scare middle school children away from cigarettes. The worst ones crunch when you handle them. The heart is hidden behind the opaque pericardial sac, which I opened gingerly with my scalpel, looking for evidence of bleeding caused by trauma or a torn vessel. The week before, I had watched Flame autopsy a patient whose heart wall had ruptured in a massive cardiac arrest, blowing out like an overinflated inner tube and resulting in a tremendous mess inside the pericardial sac. There was no hemorrhage in Terence Booker's pericardium and no sign of heart disease either. Now that the major cavities were all open and cleared of fluids, it was time to remove the organs one by one. While I did so, I took tissue samples. I keep a kitchen variety plastic cutting board on the autopsy label, lined up with histology cassettes that I fill with the things I want to look at under the microscope. Heart tissue, pieces of lung, liver, kidney, spleen, adrenal gland and pancreas. I also took separate samples for the clear plastic stock jar that sits uncovered on the cutting board. This resembles a take-out soup container, filled halfway with formalin, and serves as a sort of investigative insurance. Bits of tissue from each organ go into the preservative formaldehyde solution so that the case can be re-examined in the future if the need arises. Each autopsy gets its own dedicated stock jar, which is sealed up and stored for about a year. or sometimes longer in unresolved cases. I cut the left lung, right lung and heart loose from their vascular moorings and slid them down to the cadaver's feet, where there was plenty of room to examine and dissect them later. Some of the other MEs preferred to collect the organs on the side of the autopsy table, next to the body, but experience had taught me there is a danger of somebody's lung ending up on the floor that way. Organs are slippery. Livers are the worst. Alcoholics especially have fatty livers. Those things are as slick as greased piglets and get bobbled all over the time in the autopsy suite. The entrails are one long piece. I reached down into the pelvis through the bottom of the Y-cut and, with a scalpel, detached the bowel at the top of the rectum. I trimmed away the mesentery, a curtain of fatty tissue that anchors the intestine, and then fed it out by hand as a single rope, gathering the lower gut into a big metal mixing bowl. Once I severed the duodenum, the origin of the small intestine just south of the stomach, the intestinal tract was out. The liver is tethered by only 3 major vessels and a bunch of ligaments that attach it to the stomach and duodenum, so it's easy to remove once the intestines are out of the way. When I lifted up Terence Booker's liver, I could see large lymph nodes at the insertion point of the major blood vessels. This is a soft sign of drug use, an indicator but not proof. His spleen, right opposite the liver, looked perfectly normal. If it were bright red and mushy, he might have had a serious infection. I didn't see any evidence of traumatic injury either. Spleens are very delicate, full of tiny blood vessels and liable to rupture. Quite a number of people have 2 or 3 accessory spleens, like bright red mushrooms. Others have no spleen at all. Sometimes patients who had spleens removed due to trauma will have sprouted lots of little accessory spleens all over the abdominal cavity. The spleen is a weird organ. I pulled out the duodenum, pancreas, stomach and esophagus together and sent the whole long coil of upper guts onto the pile at the body's feet, providing me easy access to the retroperitoneal space. I peeled each kidney and its attached fat tissue away from the underlying musculature of the back and took a moment to examine Booker's adrenal glands, a pair of greasy little pyramids that perch above the kidneys like yellow garden gnome caps. Unless the adrenals are bloody and red, a sign of overwhelming systemic infection, I can't tell much by looking at them with my naked eye, so I cut a stock jar sample of each and then moved on. The last things to come out of the abdominal cavity are the bladder and rectum. Removing them requires me to reach really deep down into the pelvis, cut around the anus from the inside and pull. There is a horrible sucking sound that takes some getting used to, and if the bladder is full, it feels like a water balloon. I am careful not to burst it. Since my patient was male, I finished the prosection by collecting his testes. This is not done in the manner you might expect. Instead of cutting open Booker's scrotum, I reached down and inverted it, gaining access to his sex organs while leaving them outwardly intact. I examined the testicles one at a time, took a small section of each to save in the stock jar, and then poked them back down where they belong. Families can be very particular about the testicles, and I'd been taught to replace them unless there was a tumour or signs of injury. That first autopsy took me more than 2.5 hours, twice as much time as I would need after a couple of weeks' practice. The prosection went smoothly. I collected all the necessary samples. I didn't bobble any organs, but I learned nothing about Terence Booker's cause of death. The lab tests were no help either. Histology could neither establish nor rule out an acute sickle cell crisis. I strongly suspected Booker had died of an opiate overdose, but couldn't prove it because there was no tox report. During all the excitement that night in the hospital with the code blue alarms and the intubation and defibrillation, nobody had kept a blood sample. No blood sample, no toxicology, and no way of knowing what chemicals were in his bloodstream at the moment the patient went brain dead. After performing a meticulous autopsy with no findings, I couldn't say for sure what had killed this man. I wrote the cause of death as anoxic encephalopathy due to loss of consciousness of an undetermined etiology. This translates as lack of oxygen to the brain from fuck if I know. Worse, because I couldn't establish whether Terence Booker's loss of consciousness was due to natural disease or toxic insult, the manner of death had to be undetermined. Inconclusive, supremely frustrating, not the way I wanted to close my first case. During the next week at my new job, I would come to appreciate the wisdom of the medical school maxim, when you hear hoofbeats, think of horses, not zebras. In other words, most things are exactly what they seem, and the simplest answer is usually the right one. I autopsied a 78-year-old man with advanced heart disease and peripheral vascular disease one day, and a 55-year-old woman with even worse heart disease the next. Both had died in hospitals a few days after undergoing surgery, both for family requests. The families thought the operations had contributed to the deaths. When I opened up each body, though, I found the same thing: heart disease so far advanced that I couldn't blame the surgery, even a little, for the demise of either patient. In the coming 2 years, I would write those 5 letters, ASCVD, on a lot of death certificate worksheets. Arteriosclerotic cardiovascular disease, the biggest cause of excess mortality in the United States, kills a whole lot of New Yorkers. Traumatic death investigation is unique to forensic pathology and something I hadn't seen during my residency training. Hospital pathologists perform autopsies only on patients who have died of natural causes. My first trauma cases came over the weekend. On Saturday, I got a 62-year-old man, Johannes Roscom, who was rescued from a fire in his home only to die 3 hours later in the NYU hospital emergency room. During the morning meeting, Susan Ely handed me a burn diagram dividing the body into regions, each representing a percentage of skin surface area. One arm worth 9%, one leg 18%, for instance. As a part of Roscom's external examination, I shaded the injured areas on the diagram and calculated that thermal burns covered approximately 20% of his body. After I removed Roscom's bandages and the thick white ointment beneath them, I found that most of the injured skin was red and sloughing, with blisters around the edges and raw derma showing underneath, characteristic of a second-degree burn. Some areas showed third-degree burns with all the layers of skin reduced to carbonaceous debris, exposing yellow subcutaneous fat and muscle tissue the colour of burgundy wine. This body did not exhibit fourth-degree burns, black and white, charred all the way down to the bone. The thermal burns were severe, but they hadn't killed Johannes Roscom. He had perished like most fire victims of carbon monoxide poisoning. Carbon monoxide is a gas released during combustion which binds to the hemoglobin in red blood cells, forming carboxyhemoglobin and crowding out oxygen molecules until you asphyxiate. Once I opened up Roscom's body, I found a thick coating of black soot in his airway, nasal passages, throat and windpipe, indicating that he'd been breathing during the conflagration. When the toxicology report landed on my desk several months later, it said his carboxyhemoglobin reading was 65%, well into the lethal range. The fire marshal's report came 2 weeks after that, showing that the decedent had been smoking a cigarette in bed. The fire was accidental, which made my ruining of manner of death accident-y. At the same time on that Saturday that I'd been examining Johannes Roscom's airway, 36-year-old Julika Releva jaywalked into traffic in the middle of Amsterdam Avenue. She stepped out between 2 parked cars a few blocks north of the subway at 72nd Street and got creamed by a Mike minivan. The emergency room doctors diagnosed her crushed pelvis on X-ray, but it wasn't until that she was in the operating table that the surgeons discovered that she was pregnant. She died on the table. Just as I was starting the Y-cut on Sunday morning, a woman with a gold homicide division badge hanging from her neck came into the autopsy suite. She looked at Yulia's naked corpse. The driver of the van that hit her took off, the detective said, then turned her eyes to me with an unsettling scrutiny. Have we worked together before? It's my first week. I'm a new fellow, Judy Malinik. Cheryl Wallace. We nodded. Nobody shakes hands in the autopsy suite. Cheryl had a solid build and wore a no-nonsense suit. I couldn't read her features behind the surgical mask, but I could tell she wasn't spooked by the macabre tableau A dead woman mangled below the waist, with another woman holding a scalpel to her breast. And that's another half an hour done. We're on page 35 of Working Stiff. As I said, it's a New York Times bestseller, and it's all about Judy Melinek and TJ Mitchell, who are medical examiners.